we'll get to our first speaker. So Carolyn Murray, Dr. Carolyn Murray, is an MD and an MPH at the Dartmouth Geist School of Medicine at Dartmouth University. And she wrote a great paper that came out last, I believe it was January of 20, on some research she did working with clinicians in local clinics in small rural areas, and specifically pediatricians. And so when I saw that, I've understood, I feel like for a number of years, that we really need to reach doctors, because patients trust their doctor more than they trust anybody else. And so many people don't test and all those things. And so I introduced myself to Dr. Murray, and we're very like-minded, I believe, and I really appreciate that. And she wants to, she's really interested in all the things we can do to make well owners more safe and their health protected. And so with that, I give you Dr. Carolyn Murray.
Good morning. I'm Carolyn Murray, and I'm really pleased to be attending this year's virtual Private Well Conference, and appreciate the invitation from Steve Wilson to present some of our work at the Dartmouth Children's Environmental Health Center. My presentation today, entitled "The Role Clinicians Can Play in Engaging Well Owners to Test," stems from a research project conducted as part of the community outreach and translation core of our Children's Center. I have no disclosures or conflicts to disclose, but I do want to express my appreciation for our funders, which are the EPA and the National Institute of Environmental Health Services. So my learning objectives today are threefold. First, I want to describe some of the key findings about health effects of early life arsenic exposure from the New Hampshire Birth Cohort Study. Secondly, I hope by the end of this talk, you can describe some of the findings from an intervention study that we conducted designed to engage primary care clinicians in well water testing promotion. And lastly, I hope you'll be able to identify some ways in which clinicians can become partners in well water testing initiatives. I'd like to start first with some brief background about the Children's Environmental Health Centers. This was a national research initiative launched in the late 1990s to specifically address the gap in our understanding of how environmental exposures affect the growth and development of children from time of conception into infancy and into early and late childhood. The program goals were to better understand the effects of environmental contaminants on children's health, explore ways to reduce these threats, and to promote translation of research findings into intervention and prevention methods. Centers were selected from across the country, often due to a center's unique ability to focus on a particular hazard or hazards and an identified vulnerable population. So for example, in Central California, the opportunity to study the effect of pesticides on migrant farm worker women and their children was a unique opportunity to look at those health effects. You'll see Dartmouth up in the right-hand corner in what many would imagine and is a pristine and pastoral northern New England landscape, and wonder what could possibly be a hazard of importance that would justify federal grant funding for children's environmental health in our region. Well, New Hampshire's known for many things. Our state motto is "Live Free or Die," as my husband says, "Live, freeze, or die." And we also are known as the Granite State. What many aren't aware of is that we are really the arsenic state. Prior to the opening of the West in the late 1800s, our mines were a major source for this metalloid. And this photo is actually a graphite mine located 30 to 40 miles from the Dartmouth campus. And it was owned by the family of this famous author in the corner there, and that's Henry David Thoreau. So our unique granite geology provides an ongoing natural source of inorganic arsenic contamination of our groundwater. And this is important because private wells serve nearly 50% of our population. And the US Geological Survey estimates that at least 20% of private wells across the state exceed the EPA's maximum contaminant limit of 10 parts per billion. The map on the right is a display of measured arsenic in private wells from areas throughout the state, with the yellow, orange, and red dots showing elevations of greater than 5, greater than 10, and greater than 50 parts per billion, respectively. And this is an audience that well knows the concerns about arsenic and health, but I want to update you too on things that we're continuing to learn. Certainly, it is a known, undisputed carcinogen associated with skin, bladder, and lung cancer. And much of this early data in cancer, increased cancer, and comes from the region of Southwest Taiwan, from that map above, and the recognition of this peripheral vascular disease that causes necrosis of the distal toes, which is what led to this arsenic manifestation being referred to as Blackfoot disease. What is lesser known and appreciated is the myriad of non-cancer health effects of chronic arsenic exposure. And these have come primarily from large populations exposed in Bangladesh. You see the woman on the right pumping from what ended up being a contaminated tube well installed by the EPA. I'm sorry, installed by the WHO decades before. And studies taken from these populations that were relatively highly exposed has demonstrated that really nearly every organ system can manifest effects of arsenic, including the heart, the brain, the endocrine system, kidneys, the immune system, and population studies in Bangladesh in particular raised concerns about lifelong effects of early life exposure from arsenic. And it's estimated that over 100 million people worldwide have been exposed to arsenic in drinking water that exceeds 10 parts per billion, but there's relatively little data on the health effects of in utero and early life exposure over the lifespan in terms of health effects. And there's very little data at levels that are more common in places like the United States versus the more highly exposed populations in places like Bangladesh and Taiwan. So this brings us to why we were selected as a Children's Environmental Health Center. And this was really based on the New Hampshire birth cohort study, which was started in the in about 2008, where we recognized in our principal investigator, Margaret Carrigas in particular, that we were perfectly situated to conduct a study given that we had such a high percentage of our population on private wells. And so we partnered with obstetric colleagues and started recruiting women in pregnancy from 2 sites in New Hampshire that are circled there on the map, and enrolling them if they were between 18 to 45 years of age, were on a private water system, had just a singleton pregnancy, so not twins, and they weren't planning to move. And we enrolled them and collected at the time of enrollment in the second trimester a sample of their well water. And at entry, overall, over 15% of our moms at entry have wells that water that is exceeds the MCL. And now that we're 10 years into this study, we have over 2,000 maternal infant pairs. And with increased funding from this Children's Center, we were able to extend from just delivery to early childhood. And we're now receiving funding that's going to allow us to study children out to age 5 to 7. So we obtain biological samples from women during pregnancy, at the time of delivery, everything from placenta to cord blood to breast milk. And we follow the children and their health status onward with a special focus on immune function, vaccine response, growth, and development. We also get dietary information, so we're actually able to discriminate between arsenic that's coming from water and arsenic that's coming from food in this study. And the health impacts we're seeing actually mirror many that were noted in the Bangladesh studies, including maternal impact on blood pressure, an elevated risk of gestational diabetes related to arsenic exposure, and in babies, in utero exposure being associated with decreased head circumference on ultrasound at birth and reduced birth weight in girls. In infancy, we're seeing a heightened risk of lower respiratory infection and infections in general that are associated with even low exposure to arsenic. And we actually are able to look at the actual mechanism of this with some of our researchers actually down to the level of the cord blood, so which is the blood in the umbilical cord at birth, and looking at the impact of arsenic on the actual ways that lymphocytes and genes are expressed. So really meticulous findings of showing at just the cellular and genetic level of, and then epigenetic level of impacts on the developing fetus that have implications for lifelong health. So as director of the Outreach and Translation Corps, I joined this group in about 2014 and was really tasked with how do we get this important research out, and from a public health standpoint, how do we really look at the sort of idea of primary prevention? How do we get people to test their wells and understand the risks of arsenic exposure? And we'd had established colleagues in the state and regionally, and went to conferences. And I think, as you experienced before, a lot of times we're talking to just the same people. And that's why it's exciting for me to be here as a clinician, because I'm not normally at a private well program, and you don't often get physicians coming here. But this was really a major initiative of our center, was to reach out to the pediatric healthcare providers as a key stakeholder that had not yet been engaged by our center. And to do this, we did find a partner, and we were fortunate to have a primary care research-based network in our region that covered Vermont, New Hampshire, and Maine, and also were primarily rural. And this voluntary practice were composed of about 75 practices and over 200 clinicians. And they had experience and interest in evaluating, screening, and prevention-oriented interventions. And so we actually approached them, and they invited us to their annual meeting as they were looking for speakers. So that's the first lesson: look for speaking opportunities, don't say no. We took that opportunity to do a survey of the attendees at their annual meeting, and this was back in 2015. And at that time, these practices generally had no routine assessment of drinking water source. The only time well water would come up is when they were deciding about fluoride supplementation for babies, and that would often spur a recommendation to test their well for natural fluoride, but few followed up, and there was no recommendations beyond fluoride. The clinicians had little knowledge about arsenic or other contaminants, and expressed that they were not confident in recommending well water testing or discussing well test results. And none of the practices that these clinicians worked in had a searchable record of what a drinking water source was for their patient. And so we then looked to the literature to see what the literature said about promoting well water testing and primary care in particular. And we knew the American Academy of Pediatrics recommended routine periodic testing for a range of contaminants, including arsenic, for families with children using private wells. But we found no studies that addressed the clinical compliance with these recommendations. And the literature we did find was the literature that are in your journals, and they're on well water testing from health departments, environmental researchers, geologists, community testing initiatives, but not clinicians or healthcare systems. So we had this question of what would be the best way to integrate well water testing promotion into routine pediatric care? And could we find some practices that would be willing to explore this question with us? So we went back the next year. We got invited back to the annual meeting of this co-op. And this time we brought a map. And this is a map of New Hampshire and Vermont. Vermont's on the left, and then the yellow squiggly line in the middle is the Connecticut River, and New Hampshire's on the right. The green squares are the individual towns, and the red dots are the geocoding of the specific practices that are members of this practice-based cooperative. And the shading is reflecting the probability of elevated arsenic greater than 5 micrograms per liter, with the light being higher probability. So you see on this map that Western Vermont and Southeastern New Hampshire are particularly higher probability of increased arsenic, but we also use this opportunity to make sure that clinicians realize that probability went from low to high and was not zero, so that the recommendation to test was there, whether they were in a town where that was relatively low probability. So low probability wasn't zero probability, and the clinicians definitely understood that. And we were able to recruit 12 practices from across the 2 states that are designated here in yellow. And again, on this map, the higher probability of arsenic in groundwater is reflected by the darker red versus the lighter red. And we were able to get a good range of practices, and especially oversample in areas that had higher probability. So then we partnered with the research director of this primary care cooperative to see what would be the best way of designing a study to look at different ways we could integrate well water testing into routine pediatric care, ranging from the simplest of just handing someone a kit and hoping they actually return it to something requiring more effort from the clinic. And our study objectives were to increase the healthcare provider and their clinic staff's knowledge and self-efficacy about well testing and arsenic, identify the most effective system for integration of well testing into routine preventive care, and increase the percentage of practice households with children less than 12 months completing basic well testing, including arsenic. All practices received on-site 1-hour educational session that went over sort of well water 101. All the practices received patient educational materials and posters for their waiting rooms and exam rooms. And they also were provided reference guides for interpretation and follow-up of abnormal well test results and to health department resource. And this was very important to the practices. They did not want to be recommending a screening test that they were getting the results back for that they didn't understand how to interpret and how to refer. The design itself was parents were recruited at the time of the pediatric visit. They were eligible if they were on a private well and had a child under 12 months of age. The study design was set up to allow us to get the maximum amount of information from the smallest sample size. And the 2 factors we were looking at were receipt of who got the water test results and how much follow-up was done. And I'll talk about that in a few minutes. Practices were block randomized. So the whole practice was randomized into one of the 4 arms. We did track how each clinic operationalized the process of getting consent and handing out the kits. And the parents provided a free testing kit and a prepaid mailer. And the test was for a basic analysis, which for this setting was fluoride, arsenic, nitrates, nitrites, coliforms, and E. coli if indicated. These are just some examples of some of the promotional materials we created for the waiting rooms and the offices, some general brochures that were tailored to each of the state health departments, Vermont and New Hampshire, since some of our patient practices had patients in both states. The main takeaway from this table is just to see the 4 arms of the study. The factor on the top was the parent only getting the well water testing result versus the parent and clinic both getting the well water testing result. And on the left side was the degree of follow-up, with this square being the patient really just got handed, the family just got handed the water testing kit with no follow-up at all, and then increased follow-up in the other 3 arms. We also did results. We did do a baseline practice survey chart review at each of the sites. We looked at 30 consecutive pediatric preventive care visits in each practice just to see what they were doing at baseline. And water source was documented in 18% of those visits. However, there was no recommendation for testing other than in 10%, there was a note that private well testing for fluoride was recommended, but there was no mention of regional arsenic contamination and no tracking or notation if a family actually completed that testing. So our results were mixed. We went into this project thinking cost was going to be the biggest barrier to testing completion, which I think was naive on our part. But because I think many of you, the literature has shown that there's many barriers beyond cost. We did find that parental completion ranged from 10% to 61% in terms of returning the test results, returning the testing kits, with the average of 29%. The highest completion is in the red box here, which was the arm of the study that both the parent and the clinic got the results of the test, and the office did follow-up and tracking. And that's not surprising that the more tracking related yielded a higher percentage, although it still was only 45%. About 15% of the samples were positive for arsenic, which was reflecting the state prevalence. One unexpected finding was when we looked at who actually handed the kit to the parent. The practices across the board where the clinician actually dispensed the testing kit versus the medical assistant, there was 3 times greater odds of the testing being completed. So I think this is quite provocative in terms of thinking about the power of the clinician and actually motivating a preventive activity, and perhaps instilling a heightened concern or a willingness of a parent to complete the test. We'd like to explore that and see if we can replicate that in a further study. We did survey parents for their feedback. 70% agreed or strongly agreed that it was important for the child's clinician to know they used well water, and they also agreed that they were more likely to follow testing recommendations from a clinician. 37% had never tested their wells before. And the barriers to completing, the most significant ones were overnight shipping, which, even though we provided a prepaid mailer for FedEx, we discovered the hard way that some of these rural areas don't have a convenient FedEx box. So we lost many samples to that. And that many of the others, the second biggest barrier was the keep forgetting barrier, which has been seen and reported in other studies. Limitations included that we weren't able to determine if and how participants with abnormal tests remediated, and we couldn't calculate testing rates. We also couldn't study the actual delivery of the counseling within each practice, although all received the same education and talking points. And we didn't have demographic info on study participants, such as income and education. And we also are a region of primarily white population, English speaking. Our strengths, though, included this being the first attempt that we could find in the literature where a public health intervention of water testing was integrated into a clinical setting for children. All clinical sites were able to implement a screening system to identify families using a private well versus 0% at baseline. And providers and practices did demonstrate and follow up and improve self-efficacy in recommending well water testing. And 10 of the 12 practices engaged in continued dispensing of testing kits provided from the New Hampshire Public Health Lab. And we did succeed in making connections between a public health system and clinical care. So in conclusion, clinics with access to results and systematic follow-up did have the highest rate of completed water testing, but not that much higher than many community testing programs. Clinic education, provision of informational resources, and partnership with state health departments led to increased self-efficacy for well water screening in the healthcare setting, and we think that's really important. But testing barriers are more complex than just cost. Our current and future directions are active outreach to our obstetric providers in the state. We've been able to add some survey questions regarding arsenic, well water use and arsenic testing in our pregnancy PRAM survey. Electronic health records are a really important tool to leverage. New Jersey has done this more recently with a partnership with the health system. And we think further exploration of leveraging the patient portal for reminders, testing and referrals is going to be really critical. And promoting environmental health content and routine clinical education series, local hospitals, CME conferences has been really a useful way to get increased engagement from clinical providers, and I could recommend that to you. And we need to do a better job of understanding barriers beyond cost. So physicians and healthcare providers in general have limited knowledge about environmental health topics such as water quality, but they're willing to learn, and patients identify their clinicians as trusted resources for environmental health information. So this is a huge opportunity for partnerships between environmental public health and healthcare that I think we all need to foster. And thank you very much.
Thank you, Carolyn.
Thank you.
That
Great.
was
Great.
Oh no.
Oh no. Can you? No. Hear me?
Does it sound odd to you guys? Is everybody getting the same background I am? Carolyn, do you hear me okay, or does it sound odd?
Are you okay? It's my...
Okay, well, I'm going to go to the questions. Oh, I can't hear you. Well, this is why online is so challenging sometimes. So yeah, I'm getting feedback. Well, I'm not sure what to do here. Any suggestions? I'm going to pop the question up on the screen, the first one we got. I think the issue is that we're not going to be able to hear you.
I can do on my end.
Yeah, to me it sounds like a lot of background and it's really slow. I'm going to take...
Testing, can you hear me now?
So, yeah, I can't hear you at all. Well, you're muted. So I'm going to mute myself.
Can you hear me now? Okay.
Carolyn, you need to unmute yourself. You've muted yourself. There you go.
Okay, can you hear me now? Excellent. So you can hear me? Okay, I can't hear you, but I can answer Barbara's question. She's asking about arsenic. So we have tested this, and actually it's not, arsenic is not passed that greatly through breast milk. So that's been quite reassuring as opposed to other metalloid contaminants such as mercury. So we have, and in fact, our studies here actually have found more arsenic issues in both contamination of powdered formula and in the reconstitution of formula with water that has arsenic. So it's another emphasis on why breast is best in terms of infant nutrition.
So I'm going to manage the mic. You can hear me now, Carolyn, okay? Okay, so we're going to go ahead and do a couple questions, and I'll move on to the next one here. Go ahead.
Thanks for your question. So I think the mechanism we used was through this partnership of rural primary care clinics, and so that's obviously something that's going to be different geographically. But more and more now, health systems and even primary care practices are within a health system. And so that I would recommend that as a potential mechanism of engaging a regional system. And so we use their cooperative network and went to their annual meetings, and that's how we got our science in front of them, gave them information that they saw. Really, I mean, just the map that I showed, there were many of the practitioners who had did not grow up in rural areas and maybe relocated, and maybe they were living in the more urban area and commuting to their practice, and just did not understand the percentage of their population that were on private water systems, and that they're not regulated. I mean, so I think the gap in knowledge was definitely there, and that made once they recognized that and could sort of visually see, wow, this I live in this area and look at this probability, that actually helped significantly in getting practices engaged.
Great. Do I sound normal still? Okay, so I took off my headphones and we'll see how this works. We're going to just answer one more question because we don't want to get too far behind. There are others in the chat, and I'd ask that if you want to answer them there, that'd be greatly appreciated.
Okay.
So the next question, once you get results of the test, how do you help families make connections? This is a tough question we all deal with.
Mm-hmm. So this was a challenge, and we did have a contact in each state's health department or in their Department of Environmental Services, and we let those stakeholders knew about our study and allowed us to be able to give that kind of handoff to a practice to say, this is a good resource for understanding your options in terms of remediation, et cetera. And I think that's very important with dealing with clinicians who don't want to screen for something they can't readily connect someone into what they can do.
So, and this is a question Katie put up for me, just because a lot of us are not in the medical or public health field. So, and I know you and I have talked about this, but any quick ideas on, what's the best way to reach a clinician, really?
Yeah. And I think perhaps your medical societies, sometimes they're at a county level or state level. That is one approach. I think there's more interest in environmental health across the span of clinical education, so there may be opportunities with that. You have a medical school in your state or region. Medical students are getting very engaged with environmental health issues, and we have a chapter like here at Dartmouth that has reached out to me multiple times. So there is hope for this next generation for engagement with environmental health across the board. So those are just a few ideas.
All right. Well, hey, thank you, and thanks for your time. There were a couple other questions in the chat if you want to take a look. We're going to move on to our next presenters, I should say. And so thank you very much. That was awesome.